Hi, today we are going to discuss the renal and gastrointestinal system. We will wait a little bit for everyone. Please let me know your name in the chat box. This way we can have an interactive course. Okay. Hello, Lucas. Now, we will start in 2 minutes, so please gather up. Okay, then let's start the course. So, the first vignette is about a 65-year-old male. He presents to the emergency room with nausea and vomiting. During the last few days, he lost his balance and became incontinent, as his spouse relates. On the labs, there is no abnormality, with the exception of a creatinine of 2 mg per deciliter for a documented chronic kidney disease. He receives plenty of hydration before undergoing an MRI scan. After 2 months, the patient presents to the primary care physician due to tightening of his skin, difficulty swallowing, and reduced joint mobility. What is the most likely diagnosis? A. Systemic sclerosis diffuse form. B. Systemic sclerosis crest syndrome. C. Gadolinium-induced nephrogenic systemic fibrosis. Or D. Drug-induced lupus. Let me know your answer in the chat box. Okay, so we have an A. Does the other participant have another answer, or is it the same? Hi, Elizabeth. Pleased to meet you. So we have 2 A's. due to the fact that the patient has a documented CKD. Interesting. However, in this vignette, we have a patient that has chronic kidney disease but does not develop the tightening of his skin, the difficulty swallowing, and the reduced joint mobility up until that point. What's interesting is that if we would have a diffuse form, the reduced joint mobility is not typical of the diffused form. However, we have the information that under the conditions of a CKD, he underwent an MRI scan, and only after the MRI scan, he developed this tightening of his skin, difficulty swallowing, and reduced joint mobility. The answer, therefore, is C, gadolinium-induced nephrogenic systemic fibrosis. It can be one of the experimental questions on the USMLEs. Also, it can be one of the questions that differentiates the top performance from the mediocre ones, as the concept is rarely seen. Now, let's see what is gadolinium-induced nephrogenic systemic fibrosis. It is a rare complication in patients that have renal failure, as this patient had. It is caused by dechelation of gadolinium. The usual findings are represented by fibrosis at the level of the eye, at the level of the internal organs such as heart and kidney, at the level of the skin. This finding is specific for gadolinium-induced nephrogenic systemic fibrosis. It is represented by browny symmetric hyperpigmentation. And lastly, we will find joint contractures. Okay, are there any questions on this topic? Okay, if there are no questions, then we will pursue to the next one. Also, the newcomers, please let me know your name in the chat box so we can have a better discussion. Okay, so my screen is blocking some of the information. Let me see if I can do something. Now, that is better. Okay. This clinical vignette is about a 45-year-old patient who comes to the ED due to abdominal discomfort. In the last 3 months, he observed an increase in his abdominal girth despite maintaining the same diet. The patient comes from Nepal. His medical history consists of a previous TB infection diagnosed and treated at 25. At hospitalization, he repeated the PPD test, which returned negative. On the chest CT scan, there is a peripheral hyperechogenic rim around the heart. What is the most likely finding in this patient? A SAG greater than 1.1? Bloody diarrhea? C. Multiple hepatic nodules? Or D. Thrombosis of the hepatic vein? Please let me know your answer in the chat box. With pleasure, Elizabeth. So, do we have an answer, Elizabeth and the others? For the newcomers, please let me know your name in the chat box so we can have an interactive course. There is no problem with you not interacting, but it would be great to actually discuss these vignettes for USMLE. Okay. The next clinical vignette presents a 55-year-old female. She comes to the primary care physician due to higher than normal weight in the last 4 months. She complains of abdominal fullness. Her sister had a breast tumor at 40 years old. The physician told her that she was a carrier for a gene predisposing her to breast cancer. What is the most likely finding in this patient? An elevated creatinine and BUN, a serum albumin to ascites gradient of more than 1.1, a serum albumin to ascites gradient lesser than 1.1, or a PPD positive test. Please let me know the answer to this question in the chat box. Okay, let's see the answers. So the first answer was a SAG greater than 1.1 and the second one a SAG less than 1.1. In this case, we suspect that the patient has an ovarian cancer, whereas in this case it is obvious from the CT scan that the patient has constrictive heart failure due to a previous TB infection. Let's talk about the etiology of ascites. How can we determine the etiology of ascites? Usually we use the serum albumin to ascites gradient. If the gradient is greater than 1.1, then we suspect portal hypertension. Portal hypertension is of 3 types: pre-sinusoidal, and here we have schistosomiasis or splenic vein thrombosis, sinusoidal, namely liver failure, or post-sinusoidal. Here we have three causes: Budd-Chiari syndrome, namely the thrombosis of the hepatic veins, right heart failure, or constrictive pericarditis, as our patient had. For a gradient of less than 1.1, we can suspect TB, we can suspect malignancy with peritoneal carcinomatosis, usually ovarian cancer. As we saw in our case, the patient had a sister who had a BRCA1 mutation, which leads to increased risk of both breast and ovarian cancer. And lastly, a gradient lesser than 1.1 is seen with a nephrotic syndrome. So, are there any questions on the topic of ascites? So Elizabeth told us A, but for which vignette, Elizabeth? So for which vignette we had an A, Elizabeth, to make it clear. For the newcomers, once again, writing in the chat box allows us to firstly know each other, and secondly to have a better course by interacting and discussing each one's choices. Okay. Then, if there are no first one, oh, okay, yes, it was A for the first one, indeed, Elizabeth. If there are no questions, we will pursue further. Firstly, you can consider becoming a patron to support the channel's growth. The link is in the description. Secondly, for more USMLE related content, you can check out the playlist that is in the description. Okie dokie. Now, let's talk about renal disease. We have a 20-year-old avid consumer of energy drinks. He comes to the ED due to excruciating flank pain. The pain is continuous despite adopting different postures. On the ultrasound, there is a renal stone of less than 3 millimeters. What is the best next step in the treatment? A. Shockwave lithotripsy. B. Administer tamsulosin. C. Wait for its passage and provide oral fluids. Or D. Percutaneous nephrolithotomy. To change a little bit the pace, we will add a poll, and we are going to ask the community. Elizabeth told us that the chart is really helpful. Elizabeth and all the other participants, if you want to receive a weekly newsletter with information on USMLE such as that chart, you can subscribe to the newsletter by sending an email to medicalperspectiveblog@gmail.com. Okay, let's pursue further and talk about the next day. The patient comes again complaining that pain did not cease. On a follow-up ultrasound, the patient has a 7 mm stone now. What is the best next step? A. Administer nifedipine. B. Percutaneous nephrolithiasis. C. Wait for spontaneous passage. Or D. IV antibiotics. Let me know your answer and your argumentation in the chat box. So we have a C. Elizabeth, this C is for the first or the second question? Okay, let's see the answers. Indeed. So the first question, the renal stone has less than 3 mm. So wait for its passage and provide oral fluid. However, on the second question, the patient has a 7 mm stone. Therefore, we consider administering nifedipine. Here the answers were a little bit torn up because it was actually CNA. Let's discuss how we treat actually renal stones in accordance to their size. So, if we have a diameter less than 5 mm, we consider spontaneous passage with oral hydration. However, the best next step for a diameter between 5 and 10 mm is giving calcium channel blockers, nifedipine, or more frequently alpha blockers such as tamsulosin. If the diameter is between 10 and 20 mm, then we consider shockwave lithotripsy. Lastly, when the diameter exceeds 20 mm, we pursue a percutaneous nephrolithiasis. Are there any questions on this subject? Indeed, Elizabeth, the second question has a B as answer. Okay, hello Lucas again. So, do you have any questions on the three subjects that we covered today, namely SAAG gradient, actually the serum albumin ascites gradient, the renal stones, and gadolinium-induced nephrogenic systemic fibrosis? Lucas, don't worry, as soon as the live stream ends, you will have access to the streamed version. This way you can refer to the questions. Thanks. Okay, so if you are not subscribed, please subscribe to the channel to be notified of the live stream when it goes live. Elizabeth, I'm grateful that you participated today. Hopefully we will meet next week as well. Lucas, also, it is a pleasure, and thank you for the feedback. I wish you well, and we will see each other on the next one.